So let's start. We were doing the Maudsley Prescribing Guidelines combined study, and I will share my screen from time to time. Most of the time, it will be the Microsoft Word page. So we were doing the like we did the minimum effective doses. That, for example, the chlorpromazine minimum effective dose is 200 milligrams. Haloperidol is 2 milligrams. Sulpiride is 400 milligrams, etc. So now somebody asked that what is like I will take the question from the last time. So somebody asked from, I think it was from India, that what is panfluoridol, and I didn't know because I had never used it and I have never used it up till now. But then I searched it. So it is panfluoridol is a traditional or a typical antipsychotic. So it's in the same group as pimozide, and the group is called diphenyl butyl piperidines. So this group and antipsychotics are mostly they're not in very much use now, but especially pimozide, because I think the pimozide caused long QTC intervals, so that's why its use has been abandoned. But in the traditional texts, it is still available, and especially for different types of disorders, hypochondriasis and body dysmorphic disorder, etc. So that is pimosides. So in the same group there is panfluoridol, and it is made by several pharmaceutical industries in India. Originally, both these drugs, pimoside and panfluoridol, they were made by Janssen Pharmaceuticals or Johnson and Johnson. So now it is, but they have stopped producing it. They are Janssen are producing now risperidone, paliperidone. So, but this like the generics are produced in India, panfluoridol, and this is a very effective antipsychotic, and that's why I presume so, and that's why it's being used in India, and it doesn't have the side effect of QTC prolongation as much as it's not notorious for as much as pimozide and some other antipsychotics were notorious for. Now, the other thing is hyperbolic titration. So, titration, it means like hyperbolic tapering down of antipsychotics. So this is one thing which means that you taper down the antipsychotic at a faster rate, and later on you become slower and slower. So this is actually like parabola, but hyperbola will be something like that. So hyperbola will be like a true, it will be like a true ball. So what we can see here is that the titration rate or tapering down rate is faster in the beginning. It becomes slower, and it becomes slower and slower and slower. Now it could be like here, there could be a stepwise pattern, so it can be like that, or but a typical hyperbola will be like this, or if it is very fast, it will be like this, and if it is slower than hyperbola, then it will be like this. So this is the time, and let's see of at this. So just it's a graph to show like how it looks like. So so like we go faster in the beginning and slower and slower and slower towards the end. And these graphs are in different contexts, but when we come to the taper down regime, it is the same thing. So let's say it says wavelength here. So let's say it is the time duration, and let's say it is the dose. So like the diazepam dose, for example. So it is 100%. So you drop it to 90%, then to 80%. Then from 80% to 70%, it will take some time. And then from 70 to 60%, it will take more time and then more time. So 60 to 50% of the dose of diazepam, it will take even more time. So if it is kind of 1 month, 2 months, 3 months, 4 months, so it will be very slower and it will become slower. That is the concept of hyperbolic reduction of antipsychotics. And now the third thing somebody asked about pimavanserin mechanism of action. So pimavanserin mechanism of action is I think it works on the NMDA receptors and or glutamate receptor pathways. Yeah, I will share the screen very shortly. So, so Pimavans, sorry, you didn't see the screen, so I will share the screen and I will show you the hyperbola once again. So, yeah, now we are sharing the screen. So let's see the examples from hyperbolic reduction, which is faster in the beginning and slower towards the end. And there is an article which I will put in the group later on. So anyway, so this is hyperbolic reduction, hyperbolic tapering down the antipsychotics. Let's go to the images directly. I hope you're seeing my screen now. So this is what you're seeing is parabola, which is an inverted hyperbola. And so these are all parabolas, but when we invert it, it becomes hyperbola. So this is kind of it's here it is a good example. Can you see my screen now? I hope you can. Yes. Okay. So it says yes. Yeah. Okay. So what you can see is it was the 100% dose of diazepam. So in 1 month you like in reduce the dose for example it was let's say it was 1 month you brought it to 90%. There's a new chat. Yeah, please mic off. Other please, thank you. Please mute your mics. And yeah, okay, so then we're seeing and then 80% in the second month. So it's becoming slower and slower. So 70% it is faster, but now it will become slower and slower. So in the same duration, you will reduce less than 10% now. So it was here in 1 month you were reducing by 10%. Now here in 1 month you are reducing 9%. Now in the third month you are reducing 8%. And now you are reducing even 5%. And now you are reducing only maybe 4 to 5%. And now you're reducing only again 4 to 5%. So that's how you reduce the quantity you are reducing. You reduce the rate of titration month by month or interval by interval. So one of the known protocols for benzodiazepines tapering off is that 1/8 of the remaining dose, 1/8 of the remaining dose, not 1/8 of the original dose, but 1/8 of the remaining dose every fortnight. So if it was, let's say, if it was 64 in the beginning, 64 milligrams, so in the first fortnight you reduce diazepam to uh, let's say 56 milligrams, and then in the next fortnight you will again divide it by 8, and then you will so it this will become even less than that. I think it will be reduced by less, not 8, because you have to again take the 1/8 of the remaining. So that's how you take it. So I think you will take the 7 milligrams the next time, and then again you will divide by the 8, and then you will take less amount, and that's how you any titration which is faster in the beginning and slower towards the end, it is called the hyperbolic tapering down regime. And this formula applies to the increasing as well. So when you're increasing, let's start from here. So in the beginning, you start low, go slow, and monitor the side effects. That is the formula of starting antipsychotics, not the benzos. Even benzos should be low, but any psychotropics should be low in the beginning, and especially the antipsychotics. So you start very low and you gradually increase, and then when you are closer to the maximum dose, then your increase rate can also be increased, and then until you reach the maximum 100 dose, like 100% dose if you want. And some patients may give a response to 50%, some to 40%, some to 60%. So you don't have to go to 100% dose in each and every patient. Whenever there is a response, you can stop the increasing. And it is dependent on the receptor, receptor occupation, or so when the receptors are occupied, you see a response, and then you stop at that. So I think at 65% blockade, you can see a response without producing any extra pyramidal symptoms. And then when the 80% are blocked, then extra pyramidal symptoms can also occur. So it's not always a response is seen at 65%. Sometimes you might have to increase it to 90% or 100% before you see a response. And in those cases, you can see extrapyramidal symptoms quite easily. Now let's go to the maximum doses. So, uh, and I hope you're seeing my screen now. So this was the minimum, and then let's go to the maximum now. So chlorpromazine equivalents we usually take. So chlorpromazine equivalent will be 1000 milligrams per day will be the maximum dose. So similarly, flupentixol is 18 milligrams per day, haloperidol 20, levomepramazine. It is again one antipsychotic which is rarely used, and I have seen recently being prescribed in Ireland by some clinicians. I wasn't aware of the name before. So similarly, there will be other names which are not even mentioned here. So promazine, only promazine. So one is promazine, one is levomepramazine, one is chlorpromazine. Similarly, trifluperazine and uh, only parazine. So parazine is also available. It's used in Eastern Europe. Similarly, in India, there will be other antipsychotics which will be in use, for example, panfluoridol. So one patient came from Eastern Europe who was on parazine in some country like Romania or Poland, and we didn't have parazine in Ireland, so we put him on trifluoparazine equivalent dose, and that's why we make the equivalence of dose. uh, and equivalence of dose can easily be calculated either by these charts of minimum or maximum dose. So sulpiride is double than amisulpride. 1200 milligrams is amisulpride, and sulpiride is 2400 milligrams per day. Similarly, aripiprazole, we all know, asanapine, very equivalent to olanzapine, and then cariprazine, clozapine. So clozapine again, 900 milligram per day is the maximum, but usually, especially in the UK, we go by the serum levels. And if the levels are okay, we don't have to go to 900 milligrams. And most of the patients, they are stable at 300 milligrams. 300, 350. So 900, very very rarely we have to go. And if you are going to 900, first of all, check the levels, and secondly, go monitor for the seizures. If there are seizures, or if the person is prone to seizures, maybe add some sodium valproate, uh, or even consider augmentation at a lower dose. You don't have to go to 900 milligrams per day of clozapine. Olanzapine 20 milligrams per day. Similarly, now another thing which is struck me here is risperidone maximum dose is 16 milligrams per day. And this struck me because we seldom go above 8 milligrams, but some patients can respond up to 16 milligrams per day, and it will be within the BNF limit, and it will be within the monthly index of medicines in Ireland, which is called MIMS. So it will be within the limits if we are under 16 milligrams. All we have to do is prolactin checking, and if the prolactin is very high, we may reduce the dose a little bit and add some aripiprazole, because prolactin will be high on this dose of risperidone. Uh, and then there is equivalence of the depot medication, haloperidol. Haloperidol depot, again, it is 300 milligrams every 4 weeks. But sometimes, sometimes we have to give it weekly or 2 weekly. So we can alter the dose or the interval accordingly, but normally it should be every 4 weeks. Paliperidone depot 150 milligram per month. Now, flupentixol, the depots which are used in India and Pakistan, flupentixol or depixol, or I think it, the the tablets are called fluangzol, and I think that the trade name of the depot is may also be fluangzol in Pakistan. So flupentixol is 400 milligrams per week. That's as high you can go in flupentixol. And similarly, zuclopentixol, you can go up to 600 milligrams per week. Paliperidone depot 3 monthly, we rarely use it, but this is 525. Pipotiazine is another piportil. It was being used in UK and Ireland, but now the company has stopped producing it. And then it really irritates when the company stops producing, because our stable patients have to be moved on different depots. So if that happens, we can think of flupentixol or other types of depots. So risperidone 50 milligrams every 2 weeks, zuclopentixol 600 milligrams per week, and now the second generation blonanserin, available only in China, Japan, and South Korea. So we haven't used this blonanserin ever. Brexpiprazole is 4 milligrams per day. iloperidone, lumateperone. They're just the new names. Molindone is an old name. Pimavanserin 34 milligrams per day. Ziprasidone 160 milligrams per day. And now we go to the equivalent doses. So the equivalent doses can be calculated either from the minimum above, or it can be calculated from the maximum, or it can be like equivalence can be calculated from these tables, which just give you 100 milligrams of chlorpromazine will be equivalent to 3 milligrams per day of
May
flupentixol.
I ask a question,
Yes,
Dr.
please.
Kamran?
Yes.
So when you say the word equivalent doses, then what do you actually mean by them?
Okay. So
The
that
concept
means,
behind it, I
yeah,
want to
the
know.
concept is a patient uh, who who had been on 100 milligrams per day of thioridazine, for example. It's not given here, but somebody posted another table in the group which said that thioridazine uh, 100 milligrams per day is equivalent to chlorpromazine 100 milligrams per day. So thioridazine is an obsolete antipsychotic, but it's still available, and I think some of the Irish pharmacies have stock of it. So and one of my patients is in it, and now I'm trying to change it to chlorpromazine. So I what I would do is that I would gradually stop the 100 milligrams per day of thioridazine and start him on 100 milligrams per day of chlorpromazine. So that is the equivalent. So if you have to switch from one to another, what dose will you use? So if the patient was 100 milligrams of chlorpromazine and you have to switch to flupentixol, then it will be 3 milligrams per day. Or flupentixol depot. Again, sometimes you have to switch to depot, so you have to calculate these this equivalence. What will be the oral equivalent of chlorpromazine to risperidone, for example, and then uh, and and then what will be the equivalent from risperidone to paliperidone depot, and
So I wanted to ask that if a person is taking 20 milligrams of, for instance, if he's taking 20 milligrams of haloperidol, and if you want to put him on chlorpromazine, so the dose would be 100 milligrams a day. What if he's taking 3 milligrams of haloperidol? Still, then the
no.
equivalent dose would be
No,
100
the
milligrams.
no. If we see the equivalent, chlorpromazine 100 milligrams is equivalent to haloperidol 2 milligrams per day, not 20.
So
Okay,
if the patient is taking 20, then we'll be increasing the dose of the chlorpromazine, right? That's what
exactly,
it means.
exactly. So if the patient is on 100 uh, 2 milligrams per day of haloperidol, you are switching to chlorpromazine. Or sorry, if the patient your patient is on 20 milligrams of haloperidol, you are going to the chlorpromazine, shift to chlorpromazine. So you have to calculate the equivalence. So 20 means 2 is equal to 100. So 20 means 20 will be 1000. So,
Yeah.
so, so the patient will go to 1000 milligrams of chlorpromazine, but you have to cross taper gradually in a few weeks' time, and then you can complete the switch over.
So no, the thing is that you slowly go to the equivalent doses or you just
Yeah,
go
yeah, yeah.
once.
You
That's it.
have to go to slow. You have to go slow. Yeah. If it
Okay.
is the
Got
minimum,
it. Thank
then
you.
you can do straight away. So 100 milligrams is usually the minimum. If we go to the minimum table, it is the chlorpromazine. Yeah, first step, the minimum effective of chlorpromazine is 200, but this is min, even lower than the minimum effective. So it is the minimum dose, not even effective. So that's what we will do, is that we can, if this doses, we can easily switch from one to the other. If the dose is higher, we have to go a little bit slow. Higher the dose, slower we will go for the cross titration. That okay?
Yes, thank you.
Okay. So now we'll and then again, this is the second generation antipsychotics. So we were seeing like the amisulpride, it is, if it is 400 milligrams, we can calculate the equivalence from here. But if it is from first generation to second generation, I think we will go to the previous doses, the previous, like the minimum effective dose, which is on the page of page 9 of the book, and we can calculate the equivalences. Now the next thing is high dose antipsychotic prescribing and monitoring. So the higher doses antipsychotic prescribing and monitoring, higher doses are generally not recommended. You should not go more than the B and F limits. So let's go to the BNF here, bnf.nice.org.uk, and let's put at let's say haloperidol, and indications and dose. So it is 1 to 2 like injection, and then injection by mouth 1.5 milligrams initially, 1 to 2 milligrams, that is for nausea and vomiting, so it is recognized as an antiemetic as well. And for schizophrenia, 2 to 10 milligrams daily, maximum 20 milligrams per day. If you are exceeding 20 milligrams, if you are giving it 20 25 or 30, then you have to make a justification. You have to put something in the notes. If it is the UK, you have to sign a high dose prescribing form as well. Uh, and uh, so so you will have to put in the notes, I am using high dose and antipsychotic in this patient because because the remission has not been seen at 17.5 or 20 milligrams, and I am hopeful that there can be some remission at 25 milligrams. So you can go with slight increase in antipsychotics, and in exceptional cases, but you have to document, you have to discuss with your team, or you with your fellow psychiatrists, or with your trainees, or with the nurses, and maybe the pharmacists, that this is the rationale behind it. And you have to discuss with the patient's relatives, that yes, you are going a little bit on the higher side, just as a side of caution. So So that is one thing. And what they say is why you should not prescribe higher doses is it will be an increased side effect burden. So the more the dose, more the side effect burden is. So to put the side effect burden on a lower side, you should use less than maximum doses. And secondly, if you are combining two antipsychotics, even if they are within the range, even then you should ideally not combine unless there are any ethical or plausible combinations. So let's see, haloperidol, we saw that it was the maximum dose was 20 milligrams. So let's go for asanapine. And here is sanapine here. Asanapine indications and dose. So we are, first of all, it is not licensed for schizophrenia, but it is more for bipolar. But let's say we are using it along with olanzapine. So if necessary to 10 milligrams twice daily. So it is the same maximum dose as olanzapine. So if we are giving 15 milligrams of olanzapine, we can add 5 milligrams of uh, asanapine. So 15 plus 5 will be 20, and which will be the maximum dose. So 15, and I gave that example last time as well. 15 milligrams of olanzapine, 5 milligrams of asanapine, and that will give you the 100%. So 20 milligrams altogether. So even in the combination, you should not exceed 100% of any one drug with the combination. So if you are using 5 milligrams of olanzapine, you can give up to 15 milligrams of asanapine. The total should not go more than 20 milligrams. And that is just an example of olanzapine and asanapine. You can combine any two exceptional circumstances, but ideally the combination should not exceed 100%. If it is exceeding 100%, again it will come as a high dose prescribing, and you will have to justify, you have to say something in the notes that I am using 10 milligrams of asanapine and 15 milligrams of olanzapine. That becomes 25 milligrams. That is so more than the maximum. So it is high dose, and you have to justify the high dose prescribing. You have to write in the notes clearly. You have to discuss in your ward round with your other staff members, nurses, and your trainees and your colleagues. And you have to tell the patient that you're giving them a relatively higher dose, even with the combination. Now, why high dose should not be used routinely? Because the risks will be QTC prolongation, anticholinergic load. More you give the dose, more anticholinergic load will be, especially with the olanzapine, quetiapine, chlorpromazine. They have very strong anticholinergic properties. So that's why, and especially if you are given procyclidine, that is an anticholinergic purely. And that's why it is said that use less amount of antipsychotic rather than prescribing anticholinergic. But sometimes, of course, you have to prescribe these antipsychotics. There's no doubt about that. So sometimes, and you have to give these anticholinergics as well sometimes. But you have to bear in mind the side effects. So sedation is another thing. Postural hypotension. So postural hypotension could be sedation. All these burdens of side effects will be there, and that's why if we are within the normal range, that's fine. Anticholinergic side effects can also cause cognitive side effects. And then another one is sexual side effects. And I would like to take you to another website, medicheck.com. And there is an app as well for the same. So what it says is it gives you an overview of the side effects of the medications. Anti will be AEC, like the anticholinergic side effects, dizziness and drowsiness of each drug you put. And more you put, the more the burden will be. So let's go with the procyclidine. Procyclidine, click to add, and let's add chlorpromazine. Chlorpromazine, click to add, and let's add olanzapine as well. Olanzapine. So if we see anticholinergic burden, now the anticholinergic burden here, it is for procyclidine, it is number 2, which is the highest. So we can see a pink. And then dizziness, we can see procyclidine is not causing that much dizziness, it's only 1, but it is not 0. There is some dizziness associated with procyclidine. And drowsiness, no, it doesn't cause any drowsiness at all. Now if we go to chlorpromazine, the drowsiness is very maximum, dizziness is also up to maximum, and then anticholinergic side effects, it's also maximum. Olanzapine, it will be, again, it's very drowsiness, so it's markedly causing drowsiness. It is causing dizziness as well because of the hypotension it causes, and it is causing some anticholinergic burden as well. And total AEC score will be 8, because more antipsychotics you are giving, more the burden of side effects you are causing, and that is why polypharmacy is discouraged. If it is used, first of all, use polypharmacy in within the range, within the prescribing range of each medication. If you really have to use, if you have to use in higher doses, then uh, try to put it very clearly in the notes that you are using higher doses. If you are using monopharmacy, that is the best, except for some medications. So there are some exceptions where polypharmacy can be used and can even be helpful. One exception for so so let's complete the higher doses. So clozapine has failed. Psychological approach. Now, before using high dose, you have to see the other treatment options as well. Uh, First of all, you see whether the sufficient time has been allowed or not. And clozapine, have you tried the clozapine or not? And can it be tried or not? Is there a contraindication to the prescription of clozapine? Otherwise, uh, the guidelines say that go to the clozapine before going to the higher dose of antipsychotics. Medication adherence, sometimes putting to the depot is better than prescribing high dose because the patient is not taking it properly. And and sometimes there are other medications which may be countering the effects of the antipsychotics. And also see if there are psychological approaches or not. So if there is a high dose, it has to be made by a senior psychiatrist, involve the team, as I said, and also tell the patient, take an ECG before prescribing high dose, or before prescribing a combination high dose or a mono high dose, and then give adequate time, and again monitoring ECG, QTC, etc. Now we come to the antipsychotic polypharmacy, and I've already
Sir,
explained to you. Yes,
I would want to ask a question
yes.
that, prescribing higher doses, whatever may the reason be, are they actually helpful? Since there's given this evidence for olanzapine and lurasidone, so how effective they are actually, practically
Sometimes,
speaking?
sometimes they can be helpful. It is your clinical judgment. you want to use the higher dose of one, or if you want to use a higher dose in a combination, for example, 20 milligrams of olanzapine plus 5 milligrams of haloperidol, which will become a higher dose because with 20 milligrams of olanzapine you cannot give anything else. But if you are using 5 milligrams that is of haloperidol, that is extra. So sometimes these are helpful. It varies from patient to patient. Sometimes and it is availability of their receptors. Sometimes the receptors are upregulated, downregulated. So some patients may respond to high dose, other may respond to clozapine, and it's better to use clozapine instead of giving higher doses if the patient is not responding.
Oh,
Again,
thank you.
you have to monitor the adherence, compliance, and consider the depot before using the high doses. Because with the depot medication, you are making sure that the patient is using something. Now, polypharmacy, sometimes you use it when you're cross tapering, and sometimes you use it when you are combining the two. There could be other things which can be other risks associated with polypharmacy. There can be a likelihood of mortality as well. So you have uh, and then sometimes you have to use the depot along with some oral antipsychotics. For example, you are using depot, the patient is not still not sedated much, so you can add some olanzapine or some quetiapine. Make sure that the combination doesn't exceed the 100% of any one drug, and then you can use the combination. For example, if the patient is using the clopixol depot, you are giving it 500 milligrams every 2 weeks, and it's not working well. So maybe in the first 2 weeks you can add a little bit of olanzapine, maybe let's say 5 milligrams per day, 2.5 milligrams BD, and then in the next fortnight you now it is your choice whether to continue the olanzapine at the same dose along with the 500 milligrams fortnightly of the depot, or you want to increase the dose to 600 milligrams every fortnight. It will be your clinical decision. So this is another type of polypharmacy, depot plus oral. So depot plus oral polypharmacy, and it is relatively justified because one thing is you're giving it as a depot, but uh, with clozapine, do not give any depot antipsychotic. It's not the ideal because clozapine you are monitoring the compliance anyway. So with clozapine always give oral, but otherwise sometimes with the depots you can add some other oral antipsychotics. Now other justified so let's put the justified polypharmacy. So, so depot plus oral. Then the other could be clozapine augmentation. So sometimes you can use clozapine plus amisulpride, and sometimes you can use clozapine plus aripiprazole, clozapine plus haloperidol, clozapine plus risperidone. Again, try to make sure that the total dose does not go beyond 100%. If it is going beyond 100% of any of those, then be more and more cautious. and monitor ECG and bloods. Uh, so that is one, like clozapine augmentation is. The other type of justified polypharmacy is uh, risperidone plus aripiprazole. And what is the justification? Can anybody tell?
Yes, sir. The side effects like hyperprolactinemia that can be controlled if we give aripiprazole with risperidone,
Yeah. Okay.
or metabolic side effects as well. Other.
Yeah, exactly. Yeah, that's very good. That's very good. Yeah. So metabolic will come to that. So paste here risperidone plus or amisulpride plus aripiprazole. So that is for uh, that's for the hyperprolactinemia. Clozapine plus aripiprazole. So that is for mainly for metabolic. If the patient is not responding, then it is better to add risperidone, haloperidol, or amisulpride, some really strong antipsychotic along with clozapine. But if it is the weight issue, then add aripiprazole. And clozapine plus aripiprazole, the weight can come down a little bit. For example, the baseline weight. So let's say baseline weight of a patient is uh, 60 kg. Okay. On clozapine alone, it became 100 kg. You add aripiprazole, so clozapine plus aripiprazole, and it will come up to, let's say, 85 kg. So it is still high, but it is better. Now, another quiz is that the same patient, so baseline weight was 60 kg. You treat them with aripiprazole. The patient is prone to weight gain. There is obesity history. What weight will you accept with aripiprazole alone? Guess. I'm also guessing. Will it go to 55? Will it go to 65 or above? Will it go down or up or stay the same?
Down.
No.
No.
Aripiprazole alone will give some weight gain. 65 kg or 60 kg. It will not bring the weight down. It will either remain the same or it will be increased. That's what I'm trying to say is clozapine plus aripiprazole combination will bring down the total gained weight to like a net loss, but there will be a net gain anyway, even with the combination. So it is more than 60 anyway. You can't bring it more less than 60 or back to 60 by adding aripiprazole. Similarly, aripiprazole alone will cause some weight gain, not loss. But with clozapine, it can lead to some overall weight loss, some loss of the already gained weight. That's what I'm trying to say. Aripiprazole can cause weight gain. Similarly with metformin for metabolic syndrome. So metformin can cause some weight loss. If it was 100 milligrams, you give some metformin, it may come to 90 kilograms. Metformin alone is not like linked with weight gain anyway, because it's not an antipsychotic. But when we combine with antipsychotic, it will cause some weight loss. It will not be a very huge weight loss even with metformin, but you can try. So the other side effects, what they say is of the polypharmacy here, they say is that it is metabolic side effects. So metabolic risks can be there with combination, and paralytic ileus with more anticholinergic activity. So uh, ileus, and then seizures is another risk with the polypharmacy. Prolonged QTC. So if possible, you can, and if there is not a huge risk of relapse, you can change from polypharmacies to monopharmacy. But if the risk of relapse is very high, patient is already on a polypharmacy regime, don't touch it. That's what I normally do it. If the patient is already on a polypharmacy by the clinicians in the past, I would let it go in the same way, because otherwise we can create a risk of relapse. So there are no hard and fast rules, and we should not go from one extreme to another. We're just describing both the things and the pros and cons. So that's what we have discussed so far, that the justified use of polypharmacy in psychiatry, which is clozapine augmentation, sometimes oral plus injectable if increased sedation is required on a day-to-day basis, and sometimes for to reduce the total gained weight, for example clozapine plus aripiprazole, maybe olanzapine plus aripiprazole. I don't know if it helps or not, but what with clozapine there is more evidence. And or to bring down the prolactin levels, risperidone plus aripiprazole, or amisulpride plus aripiprazole, or haloperidol plus aripiprazole, etc. So that is it for today. If you have any questions.
Um, no, sir. Thank you.
Okay. So thank you very much. So it will be uploaded, and I'll see you all next Sunday, same time. Thank you.
Sir, may I
Yes.
ask you a question
Yes,
after the
please.
recording is stopped, maybe?
Okay. Yeah. Okay.